Good evening. I want to thank you for joining me tonight. My name is Daniel Southern, and all you need to know about me is that my clinic, Interventional Orthopedics CT, is the only Regenix affiliate in the state of Connecticut. I've been in practice 20 years. I am part of the Regenix Network, which is an affiliate of medical doctors, all dedicated to a new field of orthopedic medicine known as interventional orthopedics, which we'll discuss here shortly. The whole purpose of the webinar is to give you an overview of this new field, and discuss a few examples of what we do, trot through the literature very quickly, and then take any questions at the end. So let's get started. Regenix, where orthopedic stem cell injections were invented. In 2005, Regenix physicians were the first doctors on earth to begin treating orthopedic conditions using precise stem cell injections. And here is the case study of that first treatment. It was published in 2006. It was a 64-year-old male with very bad hip arthritis. We did 2 injections into this hip with his stem cells taken from his bone marrow. The first injection had 100,000 cells per microliter. Waited a month, did a follow-up MRI, and didn't notice much change. It was done a second time, this time with 300 to 400,000 cells per microliter. And a month after that, an MRI was obtained. This is the MRI of the hip before the injections. You can see the joint line here. This is the ball joint of the hip. This is the cup of the hip. You can see that there's a joint line here, but then it suddenly disappears here at the top, and this is classic bone on bone. This is end-stage arthritis. Well, this is the after. You can see that there is now a joint space, and more remarkably, there is a black line of neocortical formation and presumably fibrocartilage, so that he now has a joint again. All of this represents a new medical specialty known as interventional orthopedics. So what is this new field known as interventional orthopedics? Well, let's compare it to traditional orthopedics. Traditional orthopedics, they use scalpels, drills, saws, they're incising, cutting, grinding, they amputate, they're placing screws, plates, rods, nails, anchors. The analogy, the metaphor here is one of carpentry. Compare this to interventional orthopedics, where all we're using is needles and advanced imaging, both ultrasound and fluoroscopy. All we're doing is injecting. What are we injecting? We're injecting our patient's own repair cells. We're delivering growth factors to damaged tissues. The metaphor here is one of gardening. In traditional orthopedics, you remove, you rearrange tissues, you deconstruct, you reconstruct, you replace native structures. In interventional orthopedics, we don't do any of that. We attempt to stimulate the repair and regrowth of tissue. And the bottom line with interventional orthopedics is that we end up, when we're successful, we end up preserving native structures. And this is huge because the design of the human body has been refined over millenniums. And it is my experience after 20 years in medicine that you alter this design at a cost. It comes at a cost. So what is interventional orthopedics? Here's another way to express it. 95% of physicians doing ultrasound can do simple joint injections into the hip, into the knee, and into the shoulder. But only a very small fraction of physicians can hit this many targets in the hip, can hit this many targets in the knee, or in the shoulder. And this is important because interventional orthopedics is more than just taking your repair cells and throwing them into a joint. It's very, very important that you place them specifically into the tissues that are damaged. Therefore, accuracy of placement is key. So let's look at the traditional algorithm of orthopedic medicine. It starts with an injury. You injure yourself, you trip, you fall, you sprain an ankle. You do a little acute triage. You put some ice on it, you wrap it up, you take some ibuprofen, and it gets better, or it doesn't. If it doesn't get better, you go see your local doctor, and he agrees that it's bad and not getting better. He sends you to physical therapy. If physical therapy doesn't work out and you go back to the doctor, he's probably now referring you to his friend, the orthopedic, and the orthopedic will suggest that you try a steroid injection. Now, quite often this does the job, but if it doesn't and you go back to the orthopedic's office, now he's going to order an MRI. And if you're standing in an orthopedic's office and an MRI has been ordered, your chances of getting surgery go up 90%. So the MRI is reviewed with the doctor, and he sees something, maybe a little tear in the meniscus or a tear in your rotator cuff, and he recommends surgery. So let's say you have the surgery. Well, one of the dirty secrets of surgery is that surgery often leads to more surgery, and that over time, surgeries and a decade or two, and you end up getting a total joint replacement. This is the traditional arc of orthopedic medicine. So what's the difference with interventional orthopedics? Well, this algorithm is pretty much the same up until the point where you get an MRI. And if you're standing in my office and we see a tear that I think is significant in a meniscus or in a rotator cuff or in some other tissue, or you have some arthritis, I will probably suggest that you try an regenerative orthobiologic injection. This would be an injection of some of your repair cells. Following that, I'd send you back to physical therapy. And when we're successful, what we have ended up doing is preserving your native tissue and saving your joint. And what we've done, in effect, is taken you out of this algorithm, marching you towards joint replacement, and completely removed you from it altogether. So what do we treat? We treat headaches, we treat neck pain, we treat upper back pain, we treat shoulder arthritis, rotator cuff tears, and labral tears in the shoulder. We treat wrist and thumb arthritis, elbow arthritis, low back pain, sciatica, facet syndrome, disc herniations, and stenosis. We treat hip arthritis and hip labral tears. We treat knee arthritis, meniscal tears, and ACL tears, which is the anterior cruciate ligament. We treat ankle arthritis, ankle ligaments, and ankle tendons. It is very true to say that we treat virtually every joint in the body. And because I'm fellowship trained in spine and sports medicine, I also treat the neck and the back. Here's a few examples of interventional orthopedics. This is what it looks like in my procedure suite. This is a C-arm fluoroscope, and this is a fully draped knee. This is the pre-procedure MRI of that knee. You can see in the kneecap here, there's some fissuring of cartilage down here in this gray line. And what that's done is it allowed some of the joint fluid to leak into the bone, which is this white stuff here. And this is a bone lesion. And what this means is the bone is going to die if this is not treated. And you have to treat this whole area, which is known as the subchondral bone, the bone beneath the cartilage, if you're going to save the cartilage. So what we're doing here is a bone augmentation. And you can see the trocar going in here. This is the fluoroscopic view of what's happening in real time in the procedure suite. This is the trocar going into the patella. And what we're injecting here would be the patient's concentrated bone marrow, wherein we get stem cells. This is the same identical positioning for treating an anterior cruciate knee ligament. This is the cartoon of the ligaments that we're injecting, and there's two bands to the ACL, and that's a very, very important concept. You have to hit both bands, both the anteromedial and the posterolateral band. And here it is in real time. These are needles coming in, and the black stuff is the dye being taken up by the two bands of the ACL. This is the injection of a shoulder joint. The first needle placement is into the glenohumeral joint, which is represented by this curved dark line of dye. The second needle placement is into this triangular structure up here, which is the labrum. So you see how precise this type of work is. And this is a fluoroscopic view of the procedure, by the way. This is fun. This is the hydrodissection of the median nerve. The median nerve runs through your wrist. It's this nerve that's compressed when you have carpal tunnel syndrome. So I'm going to run this little video, and you will see the needle come in here. And what we're doing is we're injecting repair cells around this nerve, freeing it up from the surrounding soft tissues. And to show how delicate this work is, this is the size of a pea. So why will interventional orthopedics replace elective orthopedic surgery? Well, for one, it's less invasive. Two, it's a much quicker recovery. And three, it preserves native tissues. I should add a fourth here, is that it's very, very low risk, and then even a fifth. And the fifth reason is why I am convinced that this will eventually become part of the traditional algorithm for treatment of any orthopedic condition, at least in the view of insurance companies, because this type of work is a fraction of the cost of surgery. So what do we inject? Well, we inject orthobiologics, and these come in various flavors. So just what are orthobiologics? Orthobiologics are using a patient's biological tissue. In other words, they're repair cells, which come in two flavors, to treat orthopedic conditions. So it's a conflation of ortho and biologic. We call them orthobiologics. These are autologous, meaning self-repair tissues. We manipulate them for use in musculoskeletal injury. You have two types of repair cells. One is a small circulating blood cell known as a platelet, and this is what you may have heard of as platelet-rich plasma. We get that from your blood. That's a simple blood draw. The other repair cell is the adult human stem cell. These we get in the Regenerative world from your bone marrow. So what exactly are we doing? Let's look at a schematic rendering of the balancing in any joint of the body between forces that degrade the joint and forces that repair the joint. In degradation, you've got catabolic factors. Catabolism is simply means breakdown, and these are factors that break down the cartilage, kill the cells that keep the cartilage healthy, break down ligaments and tendons in a joint. And then you have pro-inflammatory forces that lead to chronic inflammation, and chronic inflammation does the same thing as catabolic forces. It kills things and tears up cartilage. On the other hand, you've got repair factors, anabolic, meaning forces that build up the joint, keep the joint healthy, and forces that counter the forces that break down a joint. One of the ways you can think of what we do in interventional orthopedics is we put our finger on this scale of a balance between degradation and repair. Because if you've got a painful joint, what has happened is this balance is being tipped toward the degradation breakdown side of the biological condition of your joint. So if you walk into my office and your arthritis is not very bad, but it's bothering you enough to make you have to stop walking the golf course, for example, or if you've got a small tear in a ligament or a tendon, or a small tear in a meniscus or your ACL or your rotator cuff, I might recommend a platelet-rich plasma injection. So let's assume we do a platelet-rich plasma injection. What exactly are we getting when we do that? Well, you're going to get a whole host of anti-catabolic factors. Alpha-2 macroglobulin. You're going to get interleukin receptor antagonist protein. You're going to get tumor growth factor beta, and you're also going to get TIMP, which stands for tissue inhibitor of metalloproteinases. Now, these are all anti-catabolic factors that exist in human blood serum that we have just discovered literally in the past 10 years. And they go a long way to reducing inflammation, to countering the enzymes that are digesting your joints. And in addition to these factors, you get a very powerful growth factor known as platelet-derived growth factor. Now, if your arthritis is worse, if it's pretty serious, pretty advanced arthritis, or if you have a significant tear in your ACL or in your meniscus, I would probably recommend that we use your bone marrow, wherein we have stem cells. With stem cells, you get a whole host of powerful, very powerful growth factors. These include VEGF, FGF, IGF, CXCL. And what we've done by doing either of these injections in your joint is we've now tipped the balance back towards repair, and we've emphasized the anabolic factors and the anti-catabolic factors, and we've tipped the scale in your favor in terms of a healthier joint. So we're going to focus just very quickly on 3 of the many body areas that we treat. In the knee, we're going to discuss knee arthritis in patients requiring total joint replacement. In the shoulder, we're going to discuss rotator cuff tears. And back in the knee, we're going to discuss a procedure we're very proud of as well, ACL tears. So, knee arthritis, avoiding knee replacement. We're able to help patients with severe arthritis avoid a knee replacement. Now, this is not magic, and we don't give you a new knee. But what we do is we change the chemical microenvironment inside a knee, and we stimulate the repair and regrowth of tissues in that knee. Now, hyaline cartilage is the pristine cartilage you were born with. And that remains the holy grail of orthopedics. How do you regrow hyaline cartilage? Well, it can't be done with stem cells. But with stem cells, we can stimulate the growth of a repair cartilage known as fibrocartilage. And according to our patients and our registry of outcomes, this is often good enough. We can treat mild arthritis. There's no cure for arthritis. We can't stop arthritis, but we can certainly slow it down dramatically so that we prevent it from getting significantly worse to the point where you would need a knee replacement. We can treat meniscal tears. We can treat ligament tears around the knee, including anterior cruciate ligament tears. All the outcomes we're about to discuss are following treatment with high-dose bone marrow concentrate. And this is where, like I say, in Regenix, we get stem cells. We are tracking 5,800 knees at this point, going back to 2005. 3,400 of these knees have arthritis as a primary diagnosis, 2/3 of whom are candidates for total joint replacement. According to the registry data, the people who go on to total joint replacement, that's TKA, total knee arthroplasty, total joint replacement, a year to 2 years after treatment with bone marrow at our clinics is only 12.7%. Another way to put that is 83 out of every 100 patients we treat with stem cells who has knee arthritis is happy enough after 1 to 2 years following treatment that they don't need to go on to have the joint replaced. Here's some study that is on the Regenix.com website. This is a case series of, it's large, 840 patients, showing efficacy of stem cell treatment of knee arthritis. We did a study early on in terms of dosing. What is the proper dose of stem cells required? Well, what you need is 400 million cells per microliter to get your best result. We answered that question with a very good study that we did back in 2015. And currently, we have an ongoing randomized clinical trial of bone marrow aspirate concentrate treatment of knee arthritis. And randomized clinical trials, of course, are the highest level of clinical evidence. This is some preliminary data from that randomized clinical trial, which is yet to finish. This is at the point at which we had only 48 patients. We were comparing stem cells to treatment with PT, physical therapy with the control group. And you can see the outcomes over here to date. In orange are the patients treated with stem cells. In blue are the patients treated just with physical therapy. These are functional scale scores. The functional outcomes were much greater than those attained through doing physical therapy alone. In pain, you can see that the pain reduction was greater in the patients who had their knees treated with stem cells compared to those who just got physical therapy. And overall treatment success was much greater with the stem cell treatment group. Moving on to rotator cuff repair in the shoulder, we're able to help many patients with severe shoulder arthritis avoid a joint replacement. We can treat rotator cuff tears. We can treat shoulder labral tears. Instead of surgery, what we're doing is we're injecting high-dose stem cells precisely into these tear areas or precisely into the joints of the shoulder. This is a large case series that was published in 2015. And with shoulders, what we are also have underway is a randomized clinical trial. This is a cartoon of how we inject. This is a transducer being held over the shoulder, right over the rotator cuff. And this is the needle under direct visualization going into the supraspinatus tendon of the rotator cuff. And this is how we inject with stem cells into the shoulder. This is preliminary data for the randomized clinical trial that we have underway for the stem cell treatment of rotator cuff tears. DASH scores, this is an outcome scale for the shoulder. This is the control group. This is the treated group. Lower DASH scores indicate greater improvement. You can see that the shoulders treated with stem cells so far are doing far better than those that weren't in this randomized clinical trial. Here is a dramatic before and after of one patient treated at the CSC clinic in Colorado. This is the supraspinatus tendon coming over, and you see, oops, there's a big gap. So that's a big tear. This is 6 months after treatment with this patient's bone marrow. You can see that it's not fully darkened and it's not fully mature tissue yet, but it certainly no longer has a big gap. And that's the promise of injecting stem cells into these tears. Knee ACL tear. We're able to help many patients with ACL tears and other knee or joint ligament tears. And these are the types of tears we can treat. We can treat partial tears. We can treat full thickness tears that are not retracted. We can even treat full thickness tears that are retracted as long as they're not retracted more than 1 centimeter. If they're retracted more than 1 centimeter, then yes, you need surgery. So this is back to that same slide we had earlier. This over here is the cartoon of the 2 bands of the anterior cruciate ligament that we're injecting. And this is real-time fluoroscopy showing needles going into these various bands, dark dye being injected into the bands. This is the anterior view. This is the femur bone. This is the leg bone. This is the anteromedial band. This is the posterolateral band. Very important to get both bands. This is a before and after. Here is the knee that was treated with, this is the knee before treatment with stem cells. You can see that this is the only normal looking portion of the anterior cruciate ligament. It's nice and black. This is what we call a celery stalk appearance to the ACL. It's completely torn. It's nothing but fragments of fibers, but they do tend to seemingly go from front to back. So this is an ACL that we can treat. We did. 6 months later, this is what it looked like. Almost fully matured, fully repaired, quite dramatic before and after. And we don't always get these dramatic before and afters. Say in knee arthritis, we don't often even get a follow-up MRI because we don't care what it looks like. If our patient is telling us that they're doing better, they're back on the golf course, they're back playing tennis, doing what they want to do, then we're happy. And the reason we don't get follow-up MRIs for knee arthritis is quite often there is not a whole lot of difference. But this is a case of rotator cuff tears, ACL tears. You can see a dramatic difference before and after. So that's why we like to show these. I want to end with just a caution about stem cell hype. This is a new field of medicine. For the most part, it's not being reimbursed by commercial insurers. What that means is that it is a cash-based business. Because it is a cash-based business, it attracts a lot of fraudulent players in the field. So this is just a small segment on warning. There are 3 phases of procedural adoption, meaning when a new procedure, a new field of medicine, a new procedure comes on the market, it's just remarkable. And the first phase of that procedure adoption is, hey, man, this is magic and it helps everybody. But after you do it for a while, the second phase is, hey, this is great, and it helps almost everybody. And then you do it for a few more years after that, and you get to the third phase was, hey, let's figure out who's a good candidate for this. And this is the phase that we're in. We're the only practice doing this that is in phase 3. We've done this enough to know, our data tells us that there are some people who don't respond to what we do, and there are other people who will respond. And part of what you get when you come to a Regenexx provider is that evaluation. Are you a good candidate? And we tend to put all of our patients into 3 categories, good, fair, and poor. And if you're in the poor category, we'll tell you, and we'll also tell you to save your money. Everybody else still is pretending this is magic. This is a rabbit being pulled out of a hat. As the inventors of these procedures, the biggest abuse we see is the amniotic, placental, or cord stem cell injections. This is where you walk into a clinic and they tell you, oh, we don't use your stem cells. Your stem cells are no good. No. We get stem cells from the placenta, or we're using amniotic stem cells, or cells that we get from cord blood. They're far better than yours. There are products on the market. We maintain a university-level research laboratory in Colorado, and we've obtained samples of all of these products, and we've evaluated them. And what we have found is that they are dead tissues. There is not a single living cell in any of them. And that's very important that there isn't, because number one, if there was something alive in it, that would be against the law. It's illegal under the federal code of regulations in this country. Number two, it would be, if there was a live cell in these products, it would be very dangerous for you because you have no idea of the provenance. All you know is that it's not yours, and it could trigger a very bad infection or a very bad autoimmune response. So, and these products are known by the federal government to be dead tissues because they're regulated as such. So how do they work? Do they work? Well, they may work, especially if they're injected precisely, because what we found in them is that they do contain, although they don't contain any live cells, they do contain some growth factors. But our analysis tells us that the amount of these growth factors is a tiny fraction of what a trained Regenexx physician can get out of a live patient sitting in front of them. But if you're being told that these products are a stem cell injection, that's fraud. These procedures are also often performed in a chiropractic office. There's usually no guidance whatsoever. In other words, these injections are done blind. They're not using ultrasound because they're not trained in it. They don't have a fluoroscope because it's too expensive for them to afford. It's not even being injected by the chiropractor because by law in most states, he can't inject you. So it's being done by a physician assistant or a nurse with an advanced credential. Remember, these are dead cell products, and quite often the costs of these procedures are often higher than having them performed by the world's experts in this field. Regenexx is very, very, very different from any other stem cell clinic, some of which you may have heard about because there is a big media campaign with multi-millions of dollars behind it, routinely attracting patients. The difference is that in Regenexx, we are highly trained medical doctors. All injections are performed using fluoroscopy or ultrasound or other advanced imaging guidance. All we use are your cells, and your cells are processed in a custom clean room laboratory on site. We have a multi-million-dollar research laboratory that backs up everything we do, that vets every new product on the field, because we're dedicated to advancing this field. And if you state you've got a better product than what we're using, we want to know about it. Regenexx offers a fellowship program. We are committed to training young physicians in this new field of medicine. And there are now 60 plus sites, clinics, Regenexx affiliated clinics worldwide. One final thought I want to leave you with is that the treatments that we offer in interventional orthopedics are not a terminal treatment. What is a terminal treatment? Terminal treatment is a total joint replacement. It's a box that you enter that you cannot leave. Once you've had your joint replaced, you can't have it replaced again. You can't have it unreplaced. The box of regenerative orthobiologic injection is not a box that you cannot leave. Once you had a procedure with a regenerative physician, you can go on to surgery if you felt you needed to. You can go to physical therapy. You can even have a joint replacement if you felt you needed to. There's nothing about this type of treatment that prevents you from having any other treatment, unlike a total joint replacement. That concludes the presentation. I want to thank you very much for taking a little time and listening. And I'm happy to answer any questions that you may have at this point. I'm just going to sit here for a bit if anybody has any questions. I'm not seeing any raised hands. Looks like here we have a few. All right, so I haven't figured out how to do this real time. I can't get people's voice into this, so I'm just going to read questions. This is James Lawrence. I did a teleconsult with Dr. Centeno about a month ago to consider whether I have cervical instability and I'm a good candidate for the PICL procedure. And he recommended that I do posterior PRP injections on C2 and C3, but he said that this could only be done at the Centeno Schultz in Colorado. That's not true, James. This is something that's done at every Regenix affiliate that does spine procedures. The only procedure that's only done in Colorado is the PICL procedure. So, you know, if you needed a posterior approach to the ligaments of your cervical spine, that's done in my clinic, and it's done in other Regenix clinics that do spine. Lisa had a question. You didn't mention the foot. Are you able to do these injections into the foot rather than the ankle? You bet we are. I just did a third and fourth metatarsal fracture that was non-union and a met head necrotic condition. And we use stem cells, use a very small trocar. It's meticulous work. There's really not an area of the body that we don't treat. If it's an area of the body that we can't see with the imaging modalities that we have, which is fluoroscope and ultrasound, we don't treat it. That means, you know, internal organs. We don't treat internal organs. We treat orthopedic conditions. Yasmin missed the first 20 minutes. Sorry about that. Could you speak about bone on bone in the foot, not the ankle? Well, bone on bone is a term that's thrown around loosely by orthopedics. It's very expressive, and of course, what it kind of conveys is like, it's done, it's got to be replaced. You know, terrible. It means that it's probably advanced arthritis, and yes, we get bone on bone advanced arthritis in the foot and not the ankle. This is quite commonly at the talar navicular joint and at the subtalar joint. These are not ankle joints per se; they're joints in the foot. We treat them routinely. They're treated like any other joint. They're actually, you know, very easy to get into because they're very superficial. As you know, your foot doesn't have a whole lot of flesh on it. So yes, we routinely treat these. You know, they can be just as crippling as ankle arthritis. We know that. They're treated no differently. If it's mild, we'll treat it with platelets. If it's severe, we'll treat it with your bone marrow. Yeah, I hope that answers your question. We have a question from Matt. What is the timeline to do stem cell treatment? Not sure, Matt, what you mean. Let's see. Matt, are you there? Can you hear me? Matt? Yeah, I have the speaker on. This is my problem. I can't seem to hear people talking. What is the timeline to do stem cell treatment? In general, the timeline is the earlier the better. If you're, you know, committed to avoiding a joint replacement? Yeah, the sooner you do stem cells, the sooner you'll be taken out of that algorithm marching you towards joint replacement. The procedure itself is a 3-step process. It begins with a pre-injection, and that's just a simple injection done in office very quickly with some irritant solution. And what we use is 12.5% dextrose, which is sugar water. Sugar water is very irritating. Why do we do that? What we're trying to do is set off a little low level of inflammation, acute inflammation. Why is that important? Well, 2 days later when we come back, having harvested your stem cells, concentrated them down, and then we put them inside that joint. If that joint has a small level of inflammation occurring, inflammation is the biological cue for stem cells to go to work. So they get very busy very quickly. So that's why we do a pre-injection. 2 days later, we put the stem cells in, as mentioned. 2 days after that, we come back in and we feed the stem cells by taking some of your blood, collecting the platelets, and injecting the platelets into the joint. So it's a 3-step process in every joint in the body, with the exception of joints in the spine or neck and back treatment, in which case we just compress everything into one. It's a single day. We harvest your stem cells, we concentrate them, we put them back into your spine and call it good. And this is based on the fact that we're often treating discs. We don't want to go into the disc more than once. We go into it with a very fine needle, but nonetheless, we're still making a hole in your disc, and you do that once. You don't go in it 2 or 3 times, that's for sure. I hope that answers your question, Matt. Wendy had a question. Thanks for covering so much. Appreciate this so much. Well, thank you, Wendy. I appreciate it as well. Holly, I've had 2 lumbar fusions. They're saying I need another one for stenosis. Will this help? Excellent question, Wendy. And this is a long discussion. The short version is that the dirty secret of spinal fusion, and it's very well known in medicine, spinal fusion leads to more spinal fusion. So you've had 2, they're telling you need a 3rd. Please come in for an evaluation at a Regenerative clinic that does spine, because we're very familiar with what happens when we fuse bones in the spine. And what happens, in essence, is the fact that, I hope everybody can see me, you fuse one bone to another, you make a huge fulcrum of bone, and that's a very powerful lever arm, and it's throwing tremendous forces above and below this lever arm. And that causes breakdown of those adjacent levels, it's called, and it's called adjacent level syndrome. And so if you go to an orthopedic spine surgeon, he'll say, oh, well, we got to fuse you up here now. Well, in the Regenerative world, we take a look at it and go, if it's not too far gone, no, we can treat it. We can treat the disc. We can treat the ligaments that hold that adjacent segment together. We can treat the joints of that adjacent segment. And quite often, that's sufficient to help you avoid another lumbar spine fusion. Lewis, efficacy difference between PRP and bone marrow stem cell. It's pretty dramatic. PRP platelets are adequate for smaller problems. If you got a bigger problem, stem cells. It's just a much more powerful effect. When we do this work, what we're doing is we cause inflammation, because your body repairs itself through inflammation, and what we're doing is stimulating your body to repair itself. When we use platelets, we get inflammation, and it's painful, it's stiff, sore, swollen. When we use stem cells, oh man, it's really swollen. It's really painful for a day or 2, and the effect is just much, much larger. One of the things you pay a Regenerative physician for when you come in for your initial evaluation is for him to determine what the diagnosis is, how bad it is, and whether platelets can handle it or whether you've got to have stem cells. I hope that answers your question. Nettie, can we get a copy of the recording for review? Yes, just contact the office. Patty's happy to forward it if you want it. James, have you worked with patients of Dr. Scott Rosa? I have indeed, actually quite a few. I've treated a lot of patients of Dr. Rosa's, and we routinely treat cervical instability in my office. Do you need a DMX? If we're going to nail the fact that you have cervical spine, cranial cervical instability, CCI, you need a DMX. You need a DMX properly done with proper measurements, yes. Joe, how long would you expect it to take? How long would you expect it to take positive results for a bad arthritic hip? Weeks, months, ballpark cost for such a procedure? Joe, you need to come in. You need to have an evaluation. You don't have to come in, but we need to do a Zoom. I need to see what your hip looks like. Here is one of the secrets we've learned in regenerative medicine. Of all the joints we do, hips don't do well. If you don't come in early on a hip, we probably can't help you. Our criteria is pretty strict. If you're above the age of 55 and you've lost range of motion in that hip because of arthritic change, you're probably not a good candidate for what we do. You fall into our poor category according to the data that we have on outcomes. And we'll tell you that. But we don't know until we see it. If it's arthritis I think I can treat, then what you're looking at, all our outcome data shows that on average, of all the thousands of bone marrow stem cell cases that we've done, the first blip up in the data, meaning that the pain is going down and function is increasing, is 8 to 12 weeks after we do something like this. So that's 3 months. And that's usually one of the hardest things of these procedures is the patience that was required for tissue change to begin to occur and turn things around. And that's just the beginning, because when we do bone marrow and it's successful, what we see is a rising curve of improvement, going out 12, 17 months before it levels off. And then where it levels off is the new baseline. You know, your original baseline was down here. But you go through 3 phases of healing. You go through inflammatory phase that segues into the proliferative phase. And the final phase, which is the longest phase, is remodeling. And with stem cells, that whole 3 phases goes 12 to 17 months out after we've done that procedure. So you can get improvement pretty much almost all along that range of time. So keep that in mind if you're considering a stem cell procedure. Matt, to clarify, how many days does it take from start to finish? All right, yeah, good. We usually do a Monday, Wednesday, Friday schema. It doesn't have to be that. Usually it's the standard protocol is a day in between each step. So that would be what, 5 days. That's not to say that we don't have busy people who haven't got the time, who are coming in from out of town, and they'll come in and we'll do this 3 days back to back. First day we'll do the pre-injection. Second day we'll do the harvest and the re-injection. The third day we'll do the post-injection. And I got to say, I haven't noticed any difference in outcomes doing it the 3-day protocol or the 5-day protocol. James, hope you don't mind multiple questions. No, James, I don't. Do you do DMX in your office? No, we don't. But we can direct you to where there is a good DMX, particularly if you're in our area. Of course, there's really nothing in our area. We send people to upstate New York to get a proper DMX. So call the office, James. We're happy to direct you. Okay, I think that's it. Anybody else? Any more questions? I want to thank you all for attending. And I want to thank you all for your questions. Very good questions. Anybody else typing a question? Nettie had a question. Also, is there an age cutoff for harvesting stem cells? It's a good question, Nettie. No, there is not. One of the first stem cell bone marrow cases I did was on a 93-year-old gentleman. And of course, the family said, no, there's no way he's having surgery. And the knee was very badly arthritic. And he came in, we did the procedure, I injected him. About 6 weeks later, I got a call from the physical therapist. She was, I want to come see you. I'd never met this woman. She didn't live in state. When she arrived in my office, she said, I was the physical therapist of that 93-year-old gentleman you did, and his improvement was so dramatic. I said, I have to come in for my knee. And when we started doing this back in 2005, we thought that, because we know as we get older, our stem cell population decreases, but we've countered that in the Regenix world with our ability to harvest stem cells. We've gotten very good at it. We have some proprietary techniques that allow us to get more cells out of your bone marrow. And that's allowed us to keep hitting this mark of 400,000 cells per microliter. As long as you hit that mark, you're going to get a good result. And we do it fairly routinely. So to answer your question, no, there isn't an age cutoff for stem cells. Lisa, thank you. Thank you, Lisa. Roseanne, thank you, Roseanne. Matt, pleasure having you. And I will say hi to her. Have a good night. Okay, I think that concludes the presentation. And I hope everybody's enjoyed it. I certainly have. And we'll have another one soon in the future. Any further questions? Call the office. I like to talk about what I do, and we can certainly do that. Set up a Zoom and get me some images of what your issue is, and I'll give you an opinion. Thanks again, everybody. Have a good night.